of crooked legs, double sitting, or entering. What is normal and what is not? This will be my focus today. And this is very common scenario in OPD where a lady comes with, she'll tell that Doctor साहब मेरे बच्चे के पैर टेढ़े दिखाई देते हैं. This is usually around the age of standing or just started walking. So this is very frequent complaint. And before we go into detail of these issues, I would love to introduce some basic terminology in the limb alignment of a child or a lower limb. So a bowed leg is, as the name suggests, when a leg appears like a bow, it's called bow leg. Knock knees are when they are knocking to each other. It is called knock knees. These are common layman's terms. And then comes the scientific terms of varus or valgus. Whenever the distal segment is coming to midline, that is termed as varus. And wherever the distal segment is going to away from the center of midline, that is called valgus. That's why we call it as a genu valgum or genu varum, or maybe in upper limb elbow we call cubitus varus or valgus. So the basic concept of varus and valgus is same. That's these are the terms we'll be using frequently. A few mnemonics to remember. These are like the varus has round legs, valgus has L-shaped legs, or any other mnemonic like valgum, knee are stick together, or rum forms the rounded legs. These are the various mnemonics. So the other term we will be using is tibiofemoral angle. This is clinical angle as well as radiological angle, but we commonly use clinical angle, which is common in clinical practice. This is the line formed from ASIS, that is the anterior superior iliac spine, to the center of patella, then to the center of ankle. This is called as TFA measurement. And the other terms are intermalleolar distance between the two medial malleoli in standing position, or intercondylar or inter-knee distance between two knees in the standing relaxed position. So now comes the question of what is the normal lower limb alignment pattern in children, and when we call it as crooked, and how much is normal range. So this is a very famous graph from the study of Selenius, which was published in 1975, and which shows the normal progression of lower limb alignment. It clearly shows that uh, there is physiological genu varum. Up to 15 degrees of varum is very common at the birth. While the child grows and goes around 18 months or 2 years, it crosses to the other side of the alignment. Then it becomes valgus, and it gets peak around 4 to 5 years of age, and which comes back to normal, which is the normal limb alignment. For any adult, 5 to 7 degrees of valgus is normal. But from birth, that is not the case. From birth, it comes from the opposite side of the alignment towards the valgus, and this is the normal scenario, and which is very crucial in while dealing with children with lower limb alignment issues. This is 18 months around is varus, then it changes to straightening in further years, then 3 to 4 years it might be in maximum valgus, then it comes back to normal adult valgus, which is around 7 to 10 years of age. So this picture again shows same sequence of normal physiology in two siblings. The first one has bow legs, but the adult sibling has passed on to the physiological knock knee. So this is normal sequence in normal growth of child. So in summary, we have three phases of TFA, the tibiofemoral alignment. When in phase one, from infantile physiological varus to maximum valgus, in phase two, valgus knee alignment decreases in amount to normal adult value. In phase three, it remains almost same during the adult life. So the age range at which these phases change is very controversial, and it is very variable in different ethnic groups. And there are various studies available for the a larger study available in China is of around 2,600 children, which show that there are they have very early correction of physiological virus. And the classical study of Selenius, which was published in 1975, which is quoted in almost all the standard textbook, is states that there is a wide range of normal and there is no need to do any surgical intervention in these children. Now comes about data about the Indian children. This is one of the first study done in Mumbai KEM Hospital by Dr. Vinoti, and they suggest that there is a slightly different pattern in Indian children. There is, compared to the Western literature, we have early reversal of physiological virus, less than 2 years, and late peak of maximum valgus beyond 6 years, especially in girls. The peak valgus might continue up to 7 years of age compared to the Western literature. So, virus beyond 3 years is very atypical for Indian children. So again, various studies done in India, in South CMC Vellore, so same thing, and in Northeastern children, a larger data showing a similar kind of picture where the early reversal is suggested in Indian children. So a small tabulation of various causes of Xenoverum or Velgum. Very frequent is developmental or physiological knocking in below 2 years of age and physiological bowing in less than 2 years and knocking beyond 2 years. These are most common. Then comes the metabolic causes of rickets, which is very common in Indian. Rickets also delays the normal physiological correction. So developmental or ricketic valgum verum is very common in India. The other causes are also there, which we have to rule out. Now comes the part of evaluation. How do we do it? Just like any other case, we'll do onset, any history of injury or illness. Is the deformity progressive or is it correcting? We have to ask for any older photos or x-rays to look for the sequence of events of the deformity. Ask about general health and diet of children and any other family members are affected. Generally, pathological forms of verum or valgum or any bony dysplasias are familial and that might give a clue. Then comes the examination. We have to start with screening evaluation, look at the height body proportion, syndromic cases, or maybe generalized rickets might have altered height body proportion. However, a physiological will have a normal proportion. Is it associated with any other deformities? Is the deformity symmetrical? Any asymmetry in deformity is indication towards the pathological form. Is the deformity localized to knees or ankles, or is it generalized? Are there any limb length inequalities? Limb length inequalities suggest underlying hemimelia or any limb deficiency syndrome. Now comes the measurement. Just like we discussed the TFA angle, we have to measure the TFA angle, intercondylar distance or intermalleolar distance. Measure it and record it. And at every follow-up, we have to compare how much is the measurement. Also measure the rotational profile. Sometimes the genu valgum or verum might be coexisting with the rotational malalignment, and this is how we take measurement of a tibiofemoral angle. These lines are showing from ASIs to center of patella to center of ankle, and this is a simple angle measurement device which is called goniometer, which is very easily available. This is showing intermalleolar distance measurement. Remember that all these measurements are done in standing position, so that we have to find the actual weight bearing angle. Sometimes on bed it is correctable, and on standing it gives the full picture of deformity. And now comes the question of imaging. The X-rays or any other form of imaging is not required in every case. It is very rarely required. If required, we have to do a single AP X-ray, long film, lower limb views showing femur tibia in full length with patella facing forward. Generally, an standing scanogram is imaging of choice for lower limb alignment study. And positioning of limbs is also crucial. A severe xenovalgum will not come in single cassette, so the technician will try to put it in single film, so it will give a false corrective alignment, just like in the left picture on the left side, which shows a fairly good amount of alignment. But when we take a good X-ray film with full deformity in place with patella facing forward, this is showing a huge amount of valgus. So X-ray positioning is very important also. So we have to measure the X-rays. CT, MRI are generally not required. They are required in case of pathological causes of infections or physeal bar formation. Always document the deformity. Is it increasing? Is it static, or is there any change with previous values? Lab tests are generally not required only for underlying causes. A common differentiating feature between physiological or pathological cause would be physiological pattern shows a normal change from verum to valgum at particular age range. These are generally symmetrical and very mild to moderate deformities, and it is not associated with any other underlying bony systematic disorders or any other issues. There are some causes of pathological forms of genu-valgum where we can see asymmetrical deformity because of osteochondroma. This is again infantile tibia vera, which is also called Blount's disease. It has asymmetrical proximal tibia vera. This is not typical genu verum. We can identify that this is not physiological. Sometimes there are issues like focal fibrocartilaginous defect or maybe generalized endochondromosis. There are few other causes like any tumor or trauma or infection can also cause these pathological limb malalignments. Now comes the management part. Majority of children will resolve spontaneously because this is normal pattern from go to knock knees, then to normal adult valgus. Always document with photographs or if X-rays are being taken. Always measure the deformity and quantify. The saying that genu valgum is not enough. Just measure intercondylar or intermalleolar distance and write it on paper so that during next follow-up we can compare how much is the value now. If there is a pathological issue, we have to establish the cause and then consider the treatment options customized to that pathology. Non-operative treatment like shoe wedges are not effective. They are not scientifically proved, and they should be avoided. The effectiveness of bracing is unclear. The classical mermaid brace or any form of such splintage is undesirable, and they have a rather negative effect on children, and they have no scientific proven role in correcting. So they are out of use. There is no use of prescribing them. Long leg bracing may have some doubtful role in early tibia vera, which is infantile Blount's. So again, effectiveness is very uncertain. Now comes the option of operative treatment. If needed, the objectives of operative treatment would be to correct the knee angle, then place the articular surfaces of knee and ankle in horizontal position, maintain the limb length equality, and correct any coexisting deformity. To achieve these, we have to do a meticulous pre-op planning, and all the measurements and cuts have to be measured pre-operatively. And we always follow the Bible of principles of deformity correction by Dr. Rod Pelley. And operative treatment options are guided growth or hemiepiphysiodesis. This is the latest form of treatment, or the classical form of corrective osteotomy, or a combination of both. So, what is guided growth? The growth plate is the growing area of bone where the height and the length of bone comes, which is also called epiphysis. So hemiepiphysiodesis is restricting the growth of the half of the epiphysis. If we restrict the growth of one side of the physis, the other part will continue to grow and the deformity will get controlled. So that's why this 8 plate had been designed to do this job, and this is called temporary hemiepiphysiodesis. So we'll put a plate in the case of genu valgum. We'll put a plate on the medial side. It will restrict the growth of medial side. The lateral side will continue to grow, and gradually over time it will get corrected, and the deformity will be corrected. So these are the case examples of using 8 plate in genu valgum, and it gets corrected over time. This can be used in any form of deformity, varum, valgum, or any flexion deformity or extension deformity. The concept is same to restrict the growth of deformity which is overgrowing. So the advantages of guided growth or the hemiepiphysiodesis with 8 plate is it is temporary procedure. Once the job is done, we can remove it. It is very less invasive compared to the major surgeries like osteotomy. There is quick rehabilitation. Child can walk on second day and he can resume all his activities by 1 week. While in osteotomy, we have to make him bedridden for a longer time. But it needs timely intervention because we need the other part of physis to grow to get its correction done. So it cannot be done near or after skeletal maturity. The other option is osteotomy. We'll cut the bone and we'll remove the wedge and we can do the correction of desired amount. It can be fixed with plate or maybe without a plate with K wires. The basic concept is same, and it can be again used for varum, valgum, or any other form of deformity. The advantages of osteotomies are it can correct the entire deformity in single sitting, while in 8 plate we have to wait for 6 months to 1 year, depending on the amount of deformity. The osteotomy can be done anytime before or after skeletal maturity, and it might be sometimes only option in case of severe deformity affecting ambulation or in case of skeletal dysplasias where we have very undesirable or very unpredictable results with growth plate. But disadvantages of osteotomies are it is more invasive and it's a major procedure. It has longer rehabilitation time. Obviously, because of major surgery, the cost issues are there. The implant cost is added from apart from surgery, and it is not without the known complications of major surgery or osteotomy. So factors to consider while planning treatment are the age of child, remaining growth and state of physis, severity of deformity, is it progressive, site of pathology, the deformity is coming from femur or tibia or from both. That's how we have to plan the treatment. Are there any focal lesions responsible for deformities like osteochondroma or enchondromas? Is it associated with limb length discrepancy? Tubular hemimelias or any form of hemimelias will have to be dealt on a different aspect. Is there any underlying problem with bone turnover? Is it obviously a physiological or pathological form of genital or varus? So when to refer? If the age of child is more than 7 years with no knee, or if the child presents with a bone legs beyond 3 years. So this is beyond the normal range. If it is associated with any asymmetrical deformity or any limb length inequality, a gross average value of a IMD or ICD more than 9 centimeters, or if it is associated with symptoms like pain, limp, or activity limitation. So these are the times when we have to refer genu valgum or verum. The next part of my talk would be on the other issues of double sitting, toe in and toe out. This is again another issue that parents will come with the complaint that child walks with toe, keeping toes in, or in a child is mostly sitting in W position. So again, I would like to go with some basic terminology so that we can understand the deformities better. The term version describes the normal variation in limb rotation in transverse plane. If, for example, if we talk about hip joint, the flexion and extension are in the sagittal plane, the adduction and abduction are in the coronal plane, the rotations, the internal rotation and external rotation are in the transverse plane. That is the plane where the version is described. That is the version, that is the plane we are talking while we talk about version. So, so when we talk about femoral version, it is angular difference between the transcervical and transcondylar axes. So this is transcervical means the axis of neck and the transcondylar means axis of the condyles of femur. A normal femur is anteverted. If you remember during our anatomy classes, we can easily make out that femur is anteverted. The neck is slightly ahead compared to the full shaft and the condyle. So the femur has normal 15 to 20 degrees of anteversion. This is chart showing a normal growth variation among the anteversion. So it is again very important, just like the genu valgum and verum chart, growth chart. So it starts with up to 48 degrees of anteversion in infants and it comes down to 16 degrees. So this anteversion is very high in children. So that is very crucial in managing the intoing or WCT. So this is very normal to have a very high antiversion in children and it will come down to approximately 16 degrees in adults. So like the femoral version, we measure the tibial version. It is angular difference between the transmalleolar, that is the both lateral malleoli and the knee joint axis. Normal tibia is slightly externally rotated. So torsion is abnormal version. Whenever the version is beyond two standard deviation, that will be termed as torsion. It is abnormal and it is deformity. Torsional deformity can be simple at one level or complex at two or three levels. or it can be complex with additive or compensating deformity. Normal In a normal growth physiology, the femur and tibia gradually rotate externally or laterally. Just like we discussed that anteversion is very high, it will come down to 16 degrees. Similarly, tibia is a little bit internally rotated, but with time it will get outside with growth. So various presentations in OPD will be a complaint of W sitting or in a toe in walking or a toe out walking. So the evaluation would be started with history taking, the onset of the complaint, severity, any disability. Does the child has frequent falls, or is there any history of previous treatment? Obtain a developmental history. Delayed walking or delayed milestone suggest an underlying neurological cause. Is there any family history of rotational problems? A positive family history suggests a pathological cause. Always start with screening examination, rule out any hip dysplasia or any neurological problems like CP, and measure the rotational profile and establish the level and severity of torsional problems, and record the values in degrees and write it on paper. And evaluation is done in 4 steps. Observe the child walking. When the child walks in a straight line, the foot progression angle is measured, estimated. Normally, child or any adult walks with externally rotated foot. The normal foot progression angle is around 10 to 15 degrees of external. But if the child walks with in-toeing, it will be negative. Or if he walks with extorsion or out-toeing, it will be too much of foot progression angle. So observe and measure the foot progression angle. Then assess the femoral version with internal rotation and external rotation at hip. If child has too much of internal rotation, that suggests that he has too much of femoral anteversion. Compensatory decrease in external rotation again suggests that he has too much of femoral anteversion. Likewise, we have to measure the tibial version in prone position, the thigh foot angle, the axis drawn along the thigh and axis drawn along the foot. This is the thigh foot angle. Again, in normal adult, it is outward. Any tibial intorsion or inward deformity suggests negative thigh foot angle. Assess the foot for localized pathologies of intoeing, like metatarsus adductus can add to intoeing. So rule out any local pathologies of foot. Uh, and imaging again is not required in every case. It is required only if you suspect it is pathological or if there are asymmetrical rotations or if there is need of any operative intervention. So a W sitting position is very bothering to some parents. So they'll come back with a complaint of W sitting. So what is actually W sitting? Child sits with bottom knee and feet all touching the ground, with feet resting outside of the knee. When we look from above or front, it looks like letter W. Hip is in resting position of flexion, internal rotation, and adduction. So the question comes, why do kids WC? The first and foremost common cause is the physiological femoral neck anteversion. Like we discussed, femur has around 40 to 50 degrees of anteversion in children. So the excessive amount of anteversion makes femoral internal rotation more compared to the external rotation. So child prefers to sit in internal rotation position. So it is the most common cause that because child has more of internal rotation than external rotation, he prefers to sit in the W sitting. The common pathological cause is the core weakness and poor balance. Because of trunk weakness, child doesn't is not able to support his trunk because of his weak core and back extensor muscle. So he uses the W sitting like a tripod to support his weight in an abnormal compensatory way. So that is one pathological cause. And sometimes because of habit, because child starts from crawling or kneeling position, he continues to sit on W sitting. So sometimes it is just because of habit he sits in W sitting. So what are the issues associated with W sitting? One thing, if it is because of physiological excessive anteversion, it will be associated with intoeing. And there are because of W sitting, there will be decreased core activation and trunk rotation, and child will not use his core to support his trunk. And because of W sitting, child cannot cross the midline, so the fine motor development is sometimes delayed because the bimanual and fine motor movements are developed when child crosses the midline, which is restricted because of W sitting, and it leads to poor posture of pelvis and spine, as well as it puts in abnormal stresses on joints like hip and knee, and it might lead to back and hip pain as adults. So I'll discuss solutions for W sitting here only. There are alternative ways to sit: the crisscross, that is the classical Indian position of sitting, or we can promote on a side sitting, or we can promote a long sit with the knee extended. We have to focus on core strengthening for the children, hip stretching, and parents can use verbal cues at home that whenever they see child sitting in W position, they can correct that, beta आप सीधे बैठो या change the position. And if it is bothering too much, then we can always seek help from experts from pediatric orthopedics or general orthopedics. The other complaint is in-towing, which is again physiological most of the time, but we have to rule out the pathological causes like neurological disorders, limb deficiencies, Blount's disease, or any skeletal dysplasia. This is a flow chart for assessment of in-towing. We have to screen for pathological causes of cerebral palsy, DDS, or any skeletal dysplasia. Look for rotational profile. Is there any adducted great toe? Is there any metatarsus adductus or internal tibial torsion or internal femoral torsion? These are the pathological causes of in-towing. So focus of examination is to rule out the serious causes, and we have to assess that a child has normal neurological function, and we have to confirm that the cause of problem is benign before ruling out, before labeling it as physiological. So some examples of localized causes of in-towing, like metatarsus adductus, can lead to in-towing appearance. This is searching toe because of abnormal dynamic deformity of adductor hallucis. This is example of bilateral increased internal tibial torsion leading to in-towing gait. This is asymmetrical tibial intorsion due to malunited tibial fracture leading to in-towing on one side only. This is showing out-towing where child has too much of foot progression angle, and we can see that high foot angle is too much external. Again, we have to rule out the pathological causes like neuromuscular disorder or shift capital femoral epiphysis or infantile hip contracture to rule out the pathological causes of out-towing. So the management principles for managing rotational malalignment is again lies in establishing the correct diagnosis. The malalignment is coming from femoral anteversion, or is it coming from tibia, or is it coming from metatarsus adductors, or are there any underlying neuromuscular issues, or is there any skeletal dysplasia associated? So, principle of correction or dealing with rotational malalignment would be establishing the cause and level of the deformity. And most common challenge is dealing with effectively with family, because parents are very apprehensive regarding the deformity, and they sometimes don't agree that it will get corrected without doing anything. So controlling child's walking, sitting, or sleeping position is impossible. We all know children are walking around, running around, jumping, they are naughty. And such attempts are only frustrating, and they create conflict between child and parent. Using shoe wedges or twister cables or braces are of no use. They are ineffective, and scientifically, so they don't work. They create unnecessary burden, and they are worse than any placebo. So we know that by normal physiology, lower limb turns laterally. The femoral anteversion gets corrected uh, normally, and the tibia gets normal extorsion, which is outward. Okay, so simply waiting to allow this spontaneous resolution is sometimes best for the child. The family needs to be convinced that only observation is appropriate treatment. This requires obviously careful evaluation and ruling out any pathological issue. Then we have to educate parents and reassure, and continuous follow-up might put some confidence in parents. We have to assure that only less than 1% of torsional deformities fail to resolve spontaneously and may require operative correction. And these rotational osteotomies at the level of distal tibia or at the femur, they are very effective osteotomies if the need comes for such intervention. Here, I would like to mention a interesting issue, miserable malalignment syndrome. This is an issue which is very pathologically very severe form of torsional malalignment. Here, the femur is turned inwards and tibia is turned outwards. So, if we look grossly, limb looks very much okay. But if we see very closely, the femur is very twisted inwards and tibia is twisted outwards. So it is compensatory kind of malalignment, which is grossly looking very okay, but the axis of knee flexion is not in the line of knee progression, and patella is at the disadvantageous position, which can lead to dysplastic patellar uh, sulcus deformities, patellofemoral pain, and sometimes patellar dislocation. So this needs to be dealt with double level osteotomy because femur is very much internally rotated and tibia is too much externally rotated. So we have to match both the bones in the normal alignment. So the take-home message from today's talk would be coronal and rotational deformities require thorough examination to rule out any pathological causes. Most are physiological variations, and with resolve over time, they just need better counseling and educating the parents, and if required, a frequent 6 monthly or 3 monthly follow-up and regular documentation with examination and clinical photographs is required. Refer when deformities are beyond normal age range or normal values are too much for that age. If there is any asymmetry of deformity or the deformities are multifocal, if there is any underlying bone disorder, if it is associated with limb length discrepancies, if it is associated with underlying pain or activity limitation, or if there is too much parental concern and it is difficult to counsel, then we have to refer it to an expert of limbs. So, thank you so much. Yeah. Okay.
Hello, Suresh.
Yes, sir.
Uh, uh, it was indeed a very good presentation. I just like to know one thing.
Yes.
There's a term called hyperlaxity.
Yes, sir.
How much is this hyperlaxity associated with double sitting?
Yes, sir. Because of hyperlaxity, children have abnormally range of motion, which is too much of. Like we said, the anatomy can lead to too much of internal rotation. Likewise, hyperlaxity can lead to too much of internal rotation. So children are very lax and they just fall down. So it might sometimes be a cause of WCT.
So if
And
you please.
yes, sir.
So if you have hyperlaxity with sitting,
Yes,
do
sir.
you need to look for any reason for it, any medical reason like vitamin D deficiency or maybe thyroid function to look for those situations where the muscle tone decreases?
No, sir. If it is generalized hyperlaxity and if there is no underlying syndrome of like a collagen disorder or any such causes of low tone of muscle, so if we are sure that it is not pathological hyperlaxity, it is normal hyperlaxity, then we don't need to investigate so much. But if we think it is collagen disorder, then maybe we might need to investigate further.
And one thing more, in all those cases of bullets and knock knees,
Yes, sir.
if it is coming into the pathological range, like the intermolar distance is more than 8 centimeters,
Yes, sir.
and is there anything short of surgery is also? I mean, any kind of massage, any kind of
No, sir.
exercises, nothing.
Just like the braces or the twister cables or those, the mermaid brace was very famous 20, 30 years back. They don't have any scientific proven evidence of correcting it because the physiological change is going to happen there. if it is going to happen, it will happen on its own. No brace or no massage can force it. And sometimes we see that the physiological valgum is there and it is not getting corrected by 8 or 10 years. Then it needs some form of surgical intervention. Massage or brace would not do anything.
So you want to say is that if any child who has knock knees beyond 7 years, it has
Yes,
to
sir.
be operated. Nothing short of it.
Yeah, then it needs evaluation by a pediatric orthopedic surgeon or orthopedic surgeon. Before 7 years, I would like to say that only pediatrician can keep under their watch. Crossing that
I think I lost your voice. Hello. 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 Suresh, we cannot hear you actually.
Dr. Suresh, please unmute yourself.
Hello. Hello.
Yes, we can hear you. You are sharing your screen. Yes. You move your cursor at the bottom, then it will appear that your microphone icon will appear. So move your cursor at the bottom line. Now, here you and yes. Okay, okay. So you can leave the meeting and again join. Then it will work. So it happens sometimes. It goes automatically on say speaker mode on
hello,
now.
hello. Sorry for that. So we were with the Genu thing. So I think if it is beyond the range, then we have to refer it to an expert. But it is not. It is wrong to say that beyond 7 years it is absolute indication for surgery, because sometimes we can wait for maybe 8 years, maybe 8.5 years. If it is not getting corrected, then we have to do the growth plate or hemi facility, because sometimes.
So, so for me, the message is if the child is having a bow leg beyond 3 years and
Yes, sir.
knock knees beyond 7 years, it's the time for me to refer.
Yes, sir. Yes, sir.
Okay. Thank you, Suresh. Thank you very much.
Welcome, sir.
Hello, Dr. Suresh.
जी सर.
You have presented very nicely and very simple way. My question is that most of the time parents came to us and they are very apprehensive and they ask that please do something for this boy or girl. Then what should be the counseling tips to assure them? Most of the time they are panic, they are apprehensive.
Yes, sir. What I generally start with is I show the graph and the picture that I have included in the PowerPoint, that this is the normal pattern of correction. So with visual impression and with some case examples, they get some confidence that yes, okay, this is normal thing and it will get corrected. So I find it very easy to show a graph or chart and some clinical photos of same child which got corrected over time without any intervention. So it puts some confidence. And if they are too much apprehensive, we can say that you can come back after 3 months and or 6 months and we'll not do anything. If there is anything abnormal, we can again pick it up. So I think that is how confidence can be built.
And what are the red flag signs we should look to these children so that
Sir,
we should not
uh,
miss any?
yes, sir. The basic would be the developmental history. If there is developmental history is normal, then on examination, if there is any asymmetry, कि left में बहुत ज़्यादा है, right में बहुत कम है, and if it is associated with underlying bone disorders, कि बोन लेंथ बहुत शॉर्ट है या हाइट में स्ट्रेचर में कुछ इश्यू लग रहा है एंड इफ इट इज फैमिलियल in all the siblings they have same issues or maybe in family history they had some sort of similar problems, so these might be red flags.
Okay. And how can we suspect any metabolic cause for these problems?
So metabolic cause would be from the screening examination. If I mean pediatricians are expert in rickets, so if we find any clinical signs of rickets, or if we have any abnormal body height proportion or weight for I mean height for age or such issues are any abnormal, or sometimes if we look at the hypophosphatemic rickets or such kind of pathological renal rickets childs, they have very distinct features. They have very severe amount of valgum or verum. They have very thickened bones and short, stubby kind of bones. So these might be clues to underlying pathological issues. But sometimes we come to this finding after only doing the serum calcium phosphate and ALP. But obviously we cannot do these investigation in every form. Whenever we find some form of red flag sign or something is very not normal, then we can look for x-rays and then the serum calcium phosphate ALP.
And what are the most common causes of these knock-knee and Bodex in children?
So commonest it would be physiological, or we can label it as idiopathic form. So in
Okay.
Indian children, the physiology might be changed because of underlying rickets. जैसे कि child generally has valgum up to 7 maybe 8 years, right? So child had underlying rickets also, so उसका वो थोड़ा delay हो गया, so delayed correction of physiology is sometimes there. Likewise in physiological genu verum 3 साल तक वो ठीक हो जाना चाहिए 2 साल के बाद, but sometimes because of underlying metabolic issue वो 2 साल में नहीं 3 में maybe 3.5 में ठीक हो. But the most common cause is physiological, yeah, maybe we can label it as idiopathic form.
Okay, okay. Thank you so much.
Yes, sir.
Any other question from the audience?
Dr. Suresh, can the prolonged use of steroids like nephrotic syndrome or other illnesses, can it cause some rickets or these knock knees or some knee abnormality? Steroids.
Yes, sir. I mean, steroid is known to cause generalized osteoporosis, so that effect might be there. And steroid use has been, I mean, more significantly associated with femoral head slip. There is an entity called slipped capital femoral epiphysis, means the femoral head is slipped from the physis. So steroid weakens the physis. So slipped femoral physis is very known and very well what you call described entity. So physial issues can be associated with steroid problems. As such, valgum verum is I don't know, but yeah, it hampers with bone metabolism and it causes osteoporosis.
Right. Actually, in nephrotic syndrome, we usually see blood pressure for height, but does not see for bone changes of of steroids. So that's why I asked. Our books also do not mention much about the bony changes which should be seen. So you are right that weight is not very common because of steroids. Thank
Yes,
you.
yes.
Okay. Any other question from the audience? You can unmute yourself and can ask directly. I think there is no question.
One question. I have a small query to ask. Suresh, how much
Yes.
the obesity contributes to these body deformities? Obesity.
Yes, obesity exaggerates the deformity, and for example, if child has a genu valgum and he is obese, it will put too much abnormal stress on the ligaments of knee. So the like in a genu valgum, medial side of ligaments are already on abnormal stress. So the obesity will exaggerate it and it will cause pathological knee laxity. So it adds upon the appearance and general outcome of that deformity. As such, I mean, bony deformity will not be increased with simply obesity, but the actual, just like we were discussing the clinical examination, always examination then is in standing position. This has logic of taking account of ligamentous laxity or obesity. So, in functional aspect and in a actual deformity presentation, obesity will aggravate the deformity. But yeah, at the bony level, it will not have very much effect, except unless it is a pathological obesity like any hormonal issue, or maybe like in achondroplasia or in a syndromic child which has underlying bony problem also. So I think that is how I would put it.
Thank you very much, Suresh. Thank you very much.
Yes, sir. Yeah, yeah, yeah. Thank you so much. Thank you, LAP, and thank you, Anurag, sir, Dr. Chawla, and all the attendees. Thank you so much.
Thank you so much. Thank you to Ranjan sir and Chawla sir and all the attendees of this